What is a huge challenge? The hand and the upper body. We also want to consider how to go about intervening in people who have that upper body dysfunction. Upper extremity selection usually requires three basic questions. There's a lot of evidence for this. First, if there's any voluntary muscle activity, which means can the person actually move their body. Second, does the shoulder abduct, which means can I move the shoulder sideways up? If the person is able to move their shoulder sideways up, that should be documented. Second, is there any finger extension? Can the hand go up like that? So that again becomes extremely important for us to consider. How will this person have their final outcomes in that upper body? These questions are based on the SAFE model, which means shoulder abduction and finger extension. And at day 2 of one stroke, if these movements are present, that is, your shoulder goes sideways up and your hands can just open up to some extent, there's a 98% chance that this person will be able to have some functional ability in that upper body. Functional ability means that you're actually able to use that hand to get a glass of water, not just move your hand up or down, but actually use it for different tasks that are done by your upper body. This is an important algorithm and can help a lot of healthcare providers figure out where one would stand when you first see your patients in the hospital. This applies to anyone who's going through their interventions within the first 72 hours of one stroke. So the first thing is, can the patient actually produce any voluntary muscle movement in their affected upper extremity? If yes, you want to check for the next question. Move them up into a seated position and then see if this person can actually move their shoulder against the gravity. Again, the way I described, so making them move sideways up. And if they still can, then you want to check if their forearm, if it's lying down on the table like this, and with their hands or their fingers are unsupported, and can they open their fingers at least 3 times within a minute. So that becomes an important consideration for patients to decide what interventions to give. And if the patient can actually do that, you want to start thinking about interventions like constraint-induced movement therapy, which is an intense form of intervention for the upper body, where you forcefully use this arm to perform motion. So if someone has gone through right-sided hemiplegia, you actually use a mitten on the left hand so that the left hand can't really do anything much, and all of the work is being done by the right side. So it uses the principle of repetition, intensity, use it or lose it, and use it and improve it. Other things that can also be done with the patient is doing mental practice, strengthening exercise on that hand, even doing video games and virtual reality with that hand. However, if the person cannot perform these exercises or has no voluntary motion, the exercises planned out for this person would be very different. You have to think about compensation. You want to think about reducing the swelling in that hand. You want to think about use of electrical stimulation. You want to think about use of spasticity management, which is tightness in the hand or the upper limb that's happening secondary to the stroke that one has landed up with. And you really want to protect that shoulder. Within that 72 hours, often the shoulder can become extremely weak, and one can, if mishandled, which means if you pull this person from that shoulder, which is extremely weak, it can lead to subluxation. So based on where one stands, the decision for what kind of exercise is usually made by physical therapists. This has to be reviewed at 12 weeks. And you want to follow the same protocol. You want to assess if the patient can produce any movement at that 12-week or 3-month time frame with that upper extremity. Then again, you want to see if the person cannot do that, you're still working towards improving their hand function, reducing the swelling in that hand. If they can move somewhat now with their shoulders into abduction or moving their arm away from their body, you can then start thinking about more strength training. You can think about doing some aerobic exercises for that shoulder. And then you want to still continue to see if they have some of that hand function available or not, and you continue with the interventions that will be most appropriate for that person at that 12-week time frame. It becomes extremely important that one continues to monitor patients in regular intervals. Constraint-induced movement therapy. I spoke a little bit about it. It's nothing but the forced use of the hand or that arm that has been affected because of stroke. We have some evidence for that. The evidence is this, that it may produce stronger and greater improvements than conventional therapy in terms of their muscle strength, in terms of their functional mobility. There's not much of a difference in the efficacy for improving someone's functional ability with constraint-induced movement therapy when you're comparing it with constraint-induced movement therapy with task-specific training. Finally, spasticity. It may produce some greater spasticity than modified constraint-induced movement therapy without task-specific training. So, in conclusion, when you're doing things in a modified version, things might not be as effective. And in modified version, it just means that the intensity will not be the same. But it is still found to be more effective than doing just 2 days a week of therapy, which is considered conventional therapy. So the intensity, stronger it is, the better the outcome. You also want to think about, what if I just train at home? Why do I have to go see the physical therapist? So there's some conflicting outcomes for that. There is some efficacy for home-based telerehabilitation versus in-clinic therapy for adults with stroke. And it's found that if you do home-based exercise programs, they may not be very different in efficacy compared to doing conventional therapy in the clinic. Telerehabilitation may produce greater improvements compared to standard EMG or neuromuscular electrical stimulation physical therapy. And caregiver-mediated programs can also produce greater improvements in motor function than conventional therapy. So that is all related to someone's ability to actually improve that strength in the upper limb. Balance, on the other side, has slightly different outcomes. Home-based exercise programs can produce greater improvements in balance than conventional therapy, but there is conflicting evidence that the effects of caregiver-mediated programs help to improve balance therapy. So in general, if you get an exercise that is being given by a physical therapist, it will definitely be superior to doing just caregiver-based exercise interventions, especially when it comes to your balance. And in case you can't get to the outpatient clinic, home-based exercises can still be performed, and telehealth rehabilitation can still be performed in people who've had a stroke and should be recommended to patients who have landed up with a stroke. Virtual reality. One of the new things that, is available to us now in the clinics, and also can be a common question that people can ask us. We don't have enough research, the research and the evidence is still inconclusive. And the problem is this: virtual reality may not be customized to the person who's actually coming to us in the clinic. But there are some benefits that have been associated with virtual reality, and that includes engagement, motivation, and it is a safe and effective treatment as compared when added on to conventional therapy. The good thing to understand is that in case a patient wants to do virtual therapy with you in the clinic and you don't have the ability to perform that, you can share the evidence that it is not really superior in terms of doing balance therapy or other forms of conventional therapy that one would actually do. So it becomes important that virtual reality has its own benefits, but may not be a superior intervention than doing conventional therapy. There's some wonderful resources that one can actually look into, and that includes the evidence-based review of stroke rehabilitation, which has the latest evidence that is available to us in terms of how rehabilitation for people with stroke should be done. And the second is the Academy of Neurologic Physical Therapy. It has resources for patients, resources for healthcare providers, and resources for physical therapists, occupational therapists to really see what and what not should be done in people who have landed up with a stroke. I really thank all of you for your attention to this presentation, and I hope some of the information that I've provided to you will help you either encourage, have better delivery of care, and have more impact on our people who have had a stroke. I wish you well. I hope you continue to enjoy the rest of your day. Bye-bye.